Um, this is a 54-year-old female that had right greater than left radicular pain, as well as some symptoms of myelopathy. She denied any significant balance issues or trouble with coordinated hand issues, but was having occasional kind of radiating pain to her bilateral lower extremities as well. On her motor exam, when she presented to Dr. Malone's office, she had 5 out of 5 strength throughout, and her sensation was normal, but she did have positive Hoffman reflex bilaterally, and her deep tendon reflexes were 3+ throughout. This is her cervical spine imaging. As you can see, she has reasonably well-maintained cervical lordosis, with the exception of her level at 5'6", which she has severe disc disease with an osteophyte complex anteriorly, and some loss of lordosis there. You can see with her flexion extension film, she really has no significant areas of major instability. On her MRI, interestingly enough, despite her having the, I skipped the important levels on this, I'm sorry about that. So I didn't put those on there, but she, at the level for 5'6", she has severe collapse, but she actually doesn't have any neurologic compression there, whereas at 6'7", she had a severe paracentral disc herniation into her the right side, and it's significantly compressing her right neuroforamen and the cord at that level, and causing some cord indentation. I apologize, I didn't get that MRI slice on here. So Dr. Malone talked to her at length about it. She's a very active young woman, and elected to undergo a cervical disc replacement in order to decrease the risk of adjacent segment disease, particularly at the degenerative level above, in order to treat her myeloradiculopathy from the acute disc herniation. So we did the procedure. It went smoothly in general. We tried to keep our uncovertebral resection minimal, got a pretty impressive disc herniation out and took down the PLL. And then this is our trial for the arthroplasty, and you can see it looks pretty good on the trial looks great on the lateral and the AP. It felt reasonable in there. And on the lateral with the inserter device in place, it looks pretty reasonable. And after removal, the superior end plate of the Mobi-C device dislodged, and you can see it here. It's kind of dislodged anteriorly and laterally. And so we weren't exactly 100% sure why that happened. So we tried it again. This is trial number 2. You can see that it was probably placed a little asymmetrically, and the superior end plate is kind of into the uncovertebral joint on the patient's right side. I'm sorry, their left side, and up against the end plate on the right side. So tried again, and this time did not take out the peak, or got x-rays with the implant in place, and the same thing happened. And the final try, it looked perfect with x-rays with the inserter in place, and when the inserter was pulled out, it kind of like it dislodged into a kyphotic deformity. So at this point, this is what Dr. Malone looked like, and we ultimately elected to proceed with an ACDF at that level. So,
Hey Dan, one quick question. On those films, it looks like you guys released the distraction, right? Seems like the vertebra is a little distracted, but maybe that's not the case. Maybe it's just what I'm seeing on the X-ray.
They were distracted when we put the device in, but we released the distraction completely when we took the inserter out. So that, and I'll tell you, after the first try, we thought, okay, maybe it was maybe we just didn't release it. Maybe we didn't release them enough, and that was the issue. So the second time around, we made sure to really be 100% sure we released the retractors, and it still did it. So that's a good point, and I don't think that's what it was.
You were distracted putting it in, right?
Yeah. And then
I wonder.
Did you try different size implants each time, or was it all three the same implant?
It was the same implant. So that would be another.
Because I don't know much about.
I'm sorry,
but,
not the third implant. We actually downsized the width because the thought was that this might have just been too wide here, and that's why it was kind of slipping out into the uncovertebral joint. So the third one, which was actually okay on the AP here and collapsed kind of in this kyphotic deformity, was the smaller one from a width standpoint.
Hey Dan, do you guys have pre-op FlexX films?
Oh, we do, which are right here.
Okay, thanks.
Yeah, so it's level below that collapse level.
How about just the regular lateral? Yeah, looks fine on that.
Just as a thought, I wonder if putting the cage in and not just removing the distraction, but actually turning it the other way and compressing a little bit and then pulling the peak off would have been helpful. But at the end of the day, I guess if there's not enough compression to hold this in place, I think he did the right thing. You don't want to leave an end plate that could potentially dislodge post-operatively, in the first couple of days after surgery. So I don't know what somehow the ligaments around that vertebra were not providing some kind of compression to keep this in place. And if that's the case, I think the answer is do a fusion.
Yeah, I think the worst thing we could have done would have been to try to salvage this when it clearly wasn't working. But
Dan, if you look at the actual, if you zoom in on your image on the right, the vertebral bodies are actually not kyphotic. Only the implant is.
Yeah.
Which is interesting because we look at the space for the disc, it actually looks good.
Yeah.
But the implant is clearly, I'm zoomed in here on my little what's it called, and you can definitely see that the bony edges actually look like they have a good alignment, but the TDR itself actually doesn't. That's a little bit fascinating.
And that's what we saw. That's kind of what we saw clinically. Like it just wasn't wanting. It wasn't like there was a kyphotic deformity of the actual
body, right? Yeah.
Body, and no, we were just seeing it just did not want to hold on, And I just don't think we were getting the ligament taxis to hold on. Maybe if we upsized in terms of our width, that might have made a difference. It's possible we took too much of the uncovertebral joint, and that in order to get our appropriate decompression, and that's why it didn't work. But it was kind of a frustrating situation. I looked up some case reports, and no one really describes having trouble putting it in, although I do know it happens. People talk about these as being futzy sometimes, but it's not really in the literature too much. There's a couple of cases of symptomatic segmental kyphosis that are out in the literature. Here's some kind of examples, but again, these are different than ours because this is the whole body kyphosing over, as opposed to the implant just not being tight enough. So I don't know.
Yeah, good point.
I think
you can consider here biomechanically is that she had a really stiff segment above, so you were getting no help from shared load from that that stiff and arguably really degenerative level above. And then you're right, maybe your release posteriorly was greater than your release anteriorly, but based on the alignment of vertebral bodies, I'm not sure I agree with that statement. So there's something about the biomechanical forces at that level that are you weren't able to
Yeah.
overcome.
Well, we figured we'd bring it up to the group to see if anyone had any ideas. So we were kind
It
of
looks like you
racking
almost
our
needed
brains.
to flip the implant.
I know, right?
Maybe it would have worked better. Although you can't insert it, but whatever. Huh. No, I would have done the same thing. I've been like, I'm not happy. I'm fusing it.
Yeah. So, it wasn't, ideal, but I think it was the best thing for the patient to do that. I mean, you don't want to leave the OR with this.
Yeah.
So
That raises a question: is Greg and everybody else, do you guys always have an ACDF as a backup for these cases?
I do. I just make sure, like I usually just call, whoever you typically use, make sure they have a sterile set there. A lot of times that green, we're blessed in that we have, quite a few sets that live there. So you almost always have something there, but it's nice to double check and hold it on backup just in case another room was wanting to use it or whatnot.
that's a good point.
I think this highlights the fact that you should probably have a backup set, just in case. And, it can never hurt to be prepared. So
It kind of highlights the importance of letting patients know too. Like, I mean, I don't know what your conversations are like with the disc replacement patients, but I mean, telling them that there's a possibility you wake up with a fusion is probably a wise way to go forward.
Yeah,
too.
I always tell them that,
Yeah.
we're 100% planning on the arthroplasty, but if something ain't right, we're going to fuse it, So